Hello, this is the Microbacterium and Actinomyces tutorial presented by the SchrDbb, also called Dassi Bopda, with reference Lippincott Illustrated Review of Microbiology by Cynthia Cornelissen, Bruce Fisher, and Richard Harvey. So here we're going to see medically important, we're going to see the classification of Mycobacteria and Actinomyces. So we said medically important bacteria divided into cells lacking the cell wall, cells that have rigid cell wall, and cells that are flexible. You have already seen all this. So cells having rigid cell wall are divided into simple unicellular, which are divided into intracellular and free living. So we have already seen that. And now cells having rigid cell wall also consist of filamentous cells. And filamentous cells are divided into two main groups. We have Mycobacteria and we have Actinomycetes. So under Mycobacteria, you have Mycobacterium abscessus, you have Mycobacterium avium intercellular, you have Mycobacterium bovis, you have Mycobacterium chelonae, you have Mycobacterium fortuitum, you have Mycobacterium kansasi, you have Mycobacterium lepri, Mycobacterium marinum, Mycobacterium scapulaceum, Mycobacterium tuberculosis, and Mycobacterium ulcerans. The two major mycobacteria we're going to see in these tutorials are tuberculosis and lepri. For the actinomycetes, we have Actinomyces israeli, we have Nocardia asteroides, and we have Nocardia brasiliensis. So all those are the actinomyces. So we start with this diagram of Mycobacterium. So you need to know that Mycobacterium is going to have a particular stain called the Zellnersen stain, which is for acid-fast bacilli. Is it clear? So you see the Zellnersen stain is going to stain it pinkish, as you can see here. So you have typical growth. This is a typical growth pattern of Mycobacterium. It's going to grow like cords. So you have cording of the Mycobacterium. Now, this is the incidence of nucleus of tuberculosis in United States. You need to know that tuberculosis, the increase in tuberculosis in early 90s was primarily caused by the emergence of tuberculosis in HIV-infected individuals. So in the 19th century, in the early 90s, that increase was due to HIV. Now, when we have controlled HIV and the introduction of vaccines that are going to prevent primary tuberculosis to occur, that's why you have reduced of the cases of tuberculosis, basically. So now this diagram is going to show the progression of active tuberculosis infection. So you need to know that the first thing is that for tuberculosis to occur, we first have tubercular bacilli are inhaled into the alveoli of the lungs and ingested by macrophages and not killed. So they are inhaled into the alveoli. So these are the inhaled tubercular bacilli. Is it clear? So we have alveolar macrophages. They are going to be inhaled. We have infiltrated macrophages. We have early tubercle formation. So we first have the inhaled tubercle bacilli. So when the inhaled tubercle bacilli, they're going to penetrate into Mycobacterium. But now the Mycobacterium do not degrade the inhaled bacilli. They're not going to degrade the inhaled bacilli. So that's going to result to an immune response that is going to cause the accumulation of the macrophages at that level. So when you are going to have accumulation of macrophages at that level, you are going to have the formation of early tubercles. So the tubercle bacilli multiply in macrophages and cause additional macrophages to migrate in the area, forming the first tubercle called the early tubercle. Is it clear? Now, the lymphocyte now realize that the macrophage cannot kill they realize that the macrophage cannot kill this bacilli. Is it clear? So since the macrophage cannot kill the bacilli, the lymphocytes are going to enter now in the immune response also, and they are going to come in these early tubercles. So they are going to enter the early tubercles, and now you are going to also have other macrophages which are going to be killed at this center. So it's going to produce a caseating center. So a caseous center, which just means that the center is dead, is made up of cells which are dead. So there is no nuclear cells at the level of the center of this granuloma. Is it clear? So after a few weeks, many of the macrophages die, releasing the tubercle bacilli and forming a caseous center in the tubercle, which is surrounded by a mass of macrophages and lymphocytes. The disease may become dormant in this stage. So in this stage, with casseting center, that's casseting carcinoma, the disease may become dormant. Now, in some individual, a mature tubercle may result. So that is an early tubercle. Then you have a casseting center tubercle. Then you have a mature tubercle may be formed as a firm outer layer containing fibroblasts. You may have firm outer layer containing fibroblasts, a granuloma containing a firm outer layer of fibroblasts even surround the mass of macrophages and lymphocytes. So this is to prevent the spread of that tuberculosis in the other part of the lungs and the other part of the body. Is it clear? So that's why fibroblast layer is going to surround that early tubercle to produce a mature tubercle. The casseting center enlarge. So you're going to have a casseting center is going to enlarge by the process of liquefaction. So we have liquefaction necrosis and forming a tuberculous cavity in which the bacilli multiply. So this is a casseting necrosis part. Now the next is after liquefaction. Liquefaction now continues until the tubercle rupture, allowing the bacteria to split into the bronchioles and disseminated throughout the respiratory system. So if the bacilli continue to multiply, they are going to rupture the mature tubercle, making that the fibroblasts are going to release up, and then there's going to be a spread of the microorganism all into the bronchi to lead to the progression of the tuberculosis. So this is a chest X-ray that shows some classical gun complex. That gun complex are actually complexes of mature tubercles. So those mature tubercles are actually called the gun complex. So you have gun complex here are just mature tubercles formation. Is it clear? So now, what is the staging of tuberculosis? Tuberculosis starts with primary tuberculosis. You have TB, so which is going to be where a patient is going to have a positive skin test, which is also called a Mantle test. Is it clear? So a positive skin test, which is also called a Mantle test. So we have a radiograph is negative. So in primary tuberculosis, you have no infection of the lungs. So the tuberculosis is not active. Is it clear? So you can have gun complexes and all that formation, but the radiograph is showing nothing. So here you have antibodies against tuberculosis in primary tuberculosis. Is it clear? So when you are first infected with tuberculosis, you are going to have antibodies that are going to be released against it, but you don't have effectively complexes like tuberculosis inside the lungs. So the radiograph is negative. Now, in 90% of the cases, primary tuberculosis is going to convert to latent tuberculosis, and in only 10% of cases, primary tuberculosis is going to convert now to active infection, where the TB of the skin is going to be positive, the radiograph is going to be positive, and sputum is also going to be positive. Is it clear? So that's how we make a final diagnosis of active tuberculosis. Primary tuberculosis diagnosis is made up of positive skin tests. And the skin test is, so in primary tuberculosis, the skin test is negative, the radiograph is negative when you're infected for the first time. Is it clear? Now, if there's a progressive primary infection, that's a progressive active infection, is it clear? You're going to have a TB skin infection is going to be positive, the radiograph is going to be positive, and the sputum is going to be positive. That occurs in 10% of cases. In 90% of cases, the primary tuberculosis is going to convert to a latent or dormant tuberculosis. Is it clear? Now, in that case of latent or dormant tuberculosis, you have a TB skin test as a Mantle test, which is positive, and you have a radiograph negative for the active disease. Is it clear? Now, in 90% of cases of latent tuberculosis, you have no disease. Why? In 10% of cases, latent tuberculosis is going to produce to secondary tuberculosis, that is reactivation. And when you have reactivation, the TB skin is going to be positive. When the TB skin is positive, it means that you have been exposed to disease before. The radiograph is positive and sputum is positive. When the radiograph is positive, it's just telling you that you have an active disease. And when the sputum is positive, it means that the mycobacterium is present inside the sputum. Is it clear? So those are the different forms of tuberculosis that you can have. Now, this is the Mantle skin test. So how do you do the Mantle skin test? So the Mantle skin test, what you do is that you inject the PPD. The PPD is a purified protein derivative from the Mycobacterium tuberculosis. So you inject the PPD, that's a purified protein derivative of Mycobacterium tuberculosis at the dermis of the skin. Is it clear? It's intradermal. So when you inject, after certain time, you are going to have hardening is going to develop. So after 48 to 72 hours, you are going to have different forms of indurations. Is it clear? So negative reaction is when you have an induration of 0 to 5 millimeter. Intermediate reaction is going to be 5 to 9 millimeters. It means that the patient may have some degree of antibodies. And positive reaction is when it is greater than 10 millimeter. Is it clear? So negative induration shows that it is negative. Is it induration of 10 to 0 to 5 millimeter shows is negative reaction. Intermediate reaction is when it is 5 to 9 millimeter, and when it is greater than or equals to 10 millimeter, it is a positive reaction. So the photograph of positive skin reaction you can see here. So you see that this is about something like so it's between 10 to 30, something like 20 millimeters. Is it clear? So that is the tuberculin skin test, or it's also called the Mantle test. So now the interpretation of the Mantle skin test. What's the interpretation? So an induration of greater than 5 millimeter is interpreted as a positive in the following population. If you have greater than 5 millimeter, is considered to be positive when if the person who have had contact with the infectious individual, if the person has had contact with an infectious individual, consider it to be positive. If the person has an abnormal chest radiograph, you consider it to be positive. And if the patient is HIV infected or has an other autoimmune disorder, you consider it to be positive. Mantle test. Now the next, if the induration now is greater than 10 millimeter, is interpreted when induration is greater than 10 millimeters, when is it interpreted to be positive? So in cases where you have a foreign-born person from a high prevalent country, so if you are from a high prevalent country and then you have that of greater than 10 millimeters, it means that it is positive. Resident of prison, nursing homes and other institutions, positive. Health workers, positive. And in case of person with other medical risk factors, positive. Now it is said to be absolutely in case where it is absolutely positive is when it is greater than 15 millimeters. 14 to 15 millimeters is absolutely positive. So absolute positive. So every person that has greater than 15 millimeters is said to be positive, even without any risk factor. Is it clear? So in greater than 5 millimeters, so patients that have greater than 5 millimeters are said to be positive only if they have a high risk. Is it clear? If there is a high risk of tuberculosis infection, that patient that have 5 millimeters are said to be positive. Patients that have greater than 10 millimeters are said to be positive in case of risk of tuberculosis, and patients that have greater than 15 millimeters is when you have no risk of tuberculosis. So example of cases where you have high risk of exposure to tuberculosis is when you have been exposed to a patient having tuberculosis, when you are having an abnormal radiograph, and when you have HIV. So those are the high risk cases. So in cases of normal risk or risk is when you are coming from an endemic zone of tuberculosis, when you are a health worker, when you are a person, other medical related risk factors, that's a risk. Now, if you are having no risk and you are having greater than 50 millimeter, it means that it's Mantle test positive. So this is Mycobacterium tuberculosis growth on the Lowenstein-Jansen media. This is how it's going to grow on the Lowenstein-Jansen media. Now, this is the standard therapy. The standard therapy is going to be for at least 12 months, where you do a 2 months so the standard therapy is at least of primary tuberculosis at least for 6 months, where you do a 2 months of quadritherapy you do a 2 months of quadritherapy of rifampicin, isoniazid, ethambutol, and pyrazinamide, and then later on you do a 4-month therapy of rifampicin and isoniazid. Is it clear? But in other therapies, you can do 12 months to 18 months based on the extra pulmonary tuberculosis. You can also do a short therapy. It's effective for patients with uncomplicated tuberculosis. But for complicated tuberculosis, you can go for 12 to 18 months. So Bacillus calmette and Guerin is a vaccine which is being used in order to prevent primary tuberculosis in patients. So now the next disease we're going to see now is leprosy, and leprosy now classification is going to be divided into two. We have tuberculoid leprosy and we have lepromatous leprosy. So in tuberculoid leprosy, you have lesions occur as large maculae in cooler body tissues such as the skin, especially the nose, the outer ear. So all of them, tuberculoid and lepromatous leprosy, all affect the skin. Is it clear? So in tuberculous leprosy, the difference between tuberculoid and lepromatous leprosy is that the lesion in tuberculoid leprosy occur as large maculae in cooler body parts, in the body parts which are cool, just like the nose, the outer ear, the testicles, the superficial nerve endings, and it is more of a cell-mediated immune response, and there is low infectivity. So patients which are having tuberculoid leprosy are not going to infect easily to another person. Now, for lepromatous leprosy, it is extensive erythematous macules. Here you have extensive erythematous macules. Is it clear? And papules with nodules and extensive destruction of the skin. So here you have extensive destruction of the skin. You have disfigurement. So the face is disfigured. Is it clear? The immunity is severely depressed, and then it is highly infective from one person to another. So these are the different forms of leprosy. So one person is a 13-year-old boy. This is with leprosy. So this is more of a tuberculoid leprosy because it's not disfiguring, and this other one is more of lepromatous leprosy because highly disfiguring. So this tuberculoid leprosy, you see the place where occur the ear, the nostril, underneath the chin, the cooler surface, where this occur everywhere in heat surfaces, and occur in heat, and it's going to depress the immunity and cause it also disfigurement. So for the Mycobacterium species, the summary for that is going to be the fact that it is acid-fast rot. That's the one. So that is going to be stained by the senescent stain. So the second is that it is not colored by Gram stain due to the lipid-rich cell wall. Is it clear? It is long, slender, non-motile. So it's long, slender, non-motile. It's aerobic. That's why it's going more in the lungs. It's resistant to drying. Mycobacterium tuberculosis is going to grow on specialized mediums such as the Lowenstein-Jansen agar. Is it clear? And the Mycobacterium leprae does not grow in culture. It's the only one which is culture is Mycobacterium tuberculosis. Now the Mycobacterium species, so this is Mycobacterium tuberculosis colony on the Lowenstein-Jansen media, and this is the acid fasting of Mycobacterium, showing the pinkish color of Mycobacterium. Now Mycobacterium tuberculosis is going to cause tuberculosis, and the drugs which are used for Mycobacterium tuberculosis is isoniazid, rifampicin, and pyrazinamide. You can either use ethambutol or you use streptomycin. Now for Mycobacterium leprae, it's going to cause Hansen's disease, which is also called leprosy, and to treat you use a combination of dapsone plus rifampicin plus chlorphazamine. Is it clear? So those are the drugs involved here. So the next disease, the next microorganism you're going to see is Actinomycetoma. So actinomycete. So for actinomycete, example of actinomycete, you can see Nocardia asteroides and Nocardia brasiliensis. So this is a diagram of Nocardia that you can visualize here. So this is a diagram. So for nocardia, nocardiosis is a pneumonia that is rather chronic cause that is going to result to abscess formation and extensive necrosis and cavity formation. Is it clear? So that is for nocardia. So from here we have finished with, we have visualized the most of the things involved with Mycobacterium and other filamentous microorganisms. So from here we say thanks for your kind attention. Please don't forget to like and subscribe for our channel Science Video Maker. Thank you.